Hello, everyone. Welcome, and thank you for joining our webinar today on COVID-19 vaccine. What does it mean for our transplant recipient children? I'd like to give a special thanks to the American Society of Transplantation and Transplant Families for joining together to host this event. It's important to share the missions of both of these organizations. The American Society of Transplantation is an organization dedicated to advancing the field of transplantation and improving patient care by promoting research, education, advocacy, organ donation, and service to the community through its lens of equity and inclusion. Transplant Families is here to serve pediatric transplant families and the unique challenges and celebrations they experience in their journey. They provide support, education, and hope to pediatric transplant families everywhere. My name is Ricky Graves, and I'm the moderator for tonight's session, representing transplant families. I'm also a physician liaison for the liver transplant team at Houston Methodist Hospital and a Texas Children's Heart transplant mom. This session will be recorded and posted on the Transplant Families YouTube page. Please also join us tomorrow for a special event partnered by CareDx and Transplant Families on how to advocate for the best care as a patient caregiver. Visit the Transplant Families Facebook page to register. We have a thorough presentation today given by a panel of distinguished experts in the field of pediatric infectious disease. We'll conduct a short Q&A at the end of the session, so if you have any questions during the webinar, please type them into the chat window. You can vote on the questions of most interest to you, and we'll address them during the Q&A. By the end of our webinar, we hope that you feel more comfortable and confident about the safety and efficacy of COVID-19 vaccines for your transplant children. Our goal is to educate and empower. We have a disclaimer to always run medical advice through your transplant team first. Now it's time to introduce our guest speakers for today's presentation. Dr. Kevin Downs is an attending physician in the Division of Infectious Diseases at Children's Hospital of Philadelphia, with expertise in the management and treatment of infectious diseases in solid organ transplant recipients. Dr. Downs is a core faculty member of the Center for Pediatric Clinical Effectiveness, a faculty member for the Center for Clinical Pharmacology, and an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. We also have Dr. Marian Michaels. She directs the clinical research unit and is a physician in the Division of Pediatric Infectious Diseases at Children's Hospital of Pittsburgh, as well as a professor of pediatrics and surgery at the University of Pittsburgh School of Medicine. She is recognized nationally and internationally as an authority on infections and immunocompromised hosts, particularly after transplantation. Dr. Michaels has served in numerous leadership positions both nationally and internationally, including serving as the chair of the United States OPTN Ad Hoc Disease Transmission Advisory Committee and joining the OPTN UNOS Board of Directors in 2020. Dr. Lara Danziger-Isakov is the director of Immunocompromised Host Infectious Disease and a professor at the University of Cincinnati Department of Pediatrics at Cincinnati Children's Hospital in Ohio. She focuses her research on discovering new methods to quickly diagnose and evaluate the most appropriate treatment options specific to a pathogen. Dr. Danziger-Isakov specializes in treating infections in patients who have received solid organ transplants and patients undergoing treatment for cancer. She's also the president-elect for the International Society of Heart and Lung Transplantation. Speakers, the floor is now yours.
Thanks very much for inviting us to speak today. I'm going to pull up our presentation. All right, well, thank you, everybody. We're here to answer your questions. We're going to start by giving a brief presentation. Hopefully, most of the information that you're looking for and asking about is included in this presentation, but we hope to leave time for questions and answers at the end. So please include any in the Q&A box or in the chat box of the presentation itself. Again, my name is Kevin Downs from the Children's Hospital of Philadelphia. And thanks once again for the invite to participate. So we've been dealing with COVID for a long time. We're going on 20 plus months of this pandemic, and shown here are the curves for the weekly cases per 100,000 in the population, according to the Center for Disease Control. And there's a lot of information on this graph, but what I want to highlight here is that we're still seeing a decent amount of infections in children, and we are all very excited about the new approval or authorization of vaccines in younger kids. So shown on this graph, what you can see in the middle of the figure around January was our highest peak of the pandemic, with a large number of cases in older adults and relatively few cases in pediatrics. But as you look towards the right-hand side of this figure, what you'll notice is that the yellow peaks are actually at the top, and those are kids. And what we saw was a shift in the types of patients who were getting COVID infections as a result of vaccination. I know that there's been a lot of discussion and questions about how well vaccines are working, and we're going to talk about that today. But we know that it works, and this graph shows that as well, as we saw far fewer cases in older adults than we saw earlier on in the pandemic. And you can see that, fortunately, in that gray bar on the right-hand side, it looks like we're over the most recent peak as well. When the next spike might come and how high it might get, time will tell. And to that point, these are the community transmission by county in the United States. These are two figures from different time points. So in June, on the left-hand side, was one of our lowest rates of COVID in the country. On the right-hand side was just last week. So we're making some progress. Some of the southern states that were really hit hard during the spike are starting to come out of it, but we're not out of the woods yet. And so we still need to be vigilant. And most of the COVID spikes that we were seeing recently, in fact, the vast majority of cases were due to the Delta variant. B.1.617.2, or the Delta variant, which is the dominant strain in the US and remains to be the case. This strain is more transmissible or contagious than previous variants, which is why we saw a spike despite vaccinations. But vaccines remain highly effective, especially at preventing serious infections and deaths. And as I showed the number of cases previously, the vast majority of cases in that most recent spike have been among unvaccinated individuals, which unfortunately has included younger children. And despite the success of vaccines, we can still see the breakthrough cases, but often these are asymptomatic or mildly symptomatic compared to the more severe infections we're seeing in unvaccinated individuals. Compared to adults, children and adolescents are at lower risk for severe disease. Of the more than 46 million cases of COVID that have been reported to the CDC to date, just over 20%, or 22.3%, have been in children, with around 9% of those occurring in children aged 5 to 11 years of age. This is when we take all comers since the start of the pandemic. As we move into more recent data, our younger age groups now make up more than a third of cases, close to 40% of all cases. And so this, again, is attributed to the success of vaccines and the unavailability of vaccines in this younger age group until now. And I know that many people who have been on the anti-vaccine side have said, well, COVID does not kill children. We don't need to vaccinate them. They're not going to get sick. They're not going to be hospitalized. And we know that that's not true. As of November 3rd, 2021, there were 793 deaths reported in US children from COVID-19, and 170 deaths reported in kids 5 to 11 years of age. And to put this in perspective, during a typical flu season, anywhere from 40 to 180 flu-related deaths occur. So I know this is more than just a single season. We're on 20 months or so of this pandemic, but this is not just the flu. This is a severe respiratory infection, even in young kids. And deaths don't tell the whole story of COVID, particularly for children. This is the rate of hospitalization that's estimated from a subset of data that's reported to the CDC and shown by age. 0 to 4 are the yellow line. The dotted lines on the bottom is the 5 to 11 and the dashed lines just under the yellow lines are the 12 to 17. And this is the cumulative incidence over time. And so currently, as of last week, about 1 in 1,000 children aged 0 to 4 years. And if we were to combine all these together, it's about 1 in 1,000 kids have been hospitalized with COVID-19. And that's a staggering number to imagine, especially now with a vaccine preventable illness. And as we talk about the impact of vaccines in preventing disease, we know that preventing death is not the reason that we vaccinate children. It has never been the reason that we vaccinate children. It is a reason, but it's not the reason. But it's still an important reason for COVID-19. These are common infections that we currently vaccinate against routinely for children. And the average deaths per year for those illnesses just prior to the implementation of vaccines. And we can see these are data that were presented at the ACIP meeting yesterday. COVID-19 dwarfs those infections for which we routinely vaccinate. And so, again, I don't want to say that death is the reason that we need to vaccinate. It's not, but it is an important reason. And there's so many other benefits to vaccinating beyond just preventing death in children. So an important question for this group is, are pediatric solid organ transplant recipients at higher risk from COVID-19? So do kids get sicker? Do solid organ transplant recipients get sicker from COVID-19? Unfortunately or unfortunately, there remain limited data in this. And that's a testament to all of the families and the pediatric solid organ transplant teams and recipients that have done a terrific job during this pandemic preventing infections among transplant recipients. But there are some data. This is data from a registry through the St. Jude's Hospital that's collected information about children who've been infected with COVID-19, both non-immune-compromised children, transplant recipients, and others. And these pie graphs just show the fraction of children on the left-hand side that were hospitalized from COVID-19 reported in this registry. And you can see that on the left-hand side, 81% of cases of COVID-19 reported to this registry among the general pediatric population were not hospitalized, compared to only 58% of solid organ transplant recipients. So to flip that around, 30% of solid organ transplant recipients that responded to this question were in cases that were hospitalized, compared to just 13% in the general population. And so this gives a pretty good indication that solid organ transplant recipients, when they get COVID-19, at least require increased medical care compared to other children. And that's consistent with data from adults. Adult transplant data suggests that adult patients that have undergone transplant do have more severe COVID. But it's important to recognize that pediatric solid organ transplants are not at higher risk of contracting COVID-19, and in fact may do a better job of preventing it. But when they get sick, are at increased risk. And the main factors within the transplant community that contributes to that risk is the immune suppression. So having undergone transplantation within the last few months carries a high risk, or receiving high doses of immunosuppression for other reasons, such as if your child has gone through a recent episode of rejection and has required some increase to their immunosuppression, and having other medical problems such as cancer or obesity or lung conditions, which carry risk of more severe COVID outside of transplant, also carry risks for pediatric transplant recipients. And I just wanted to take a second and ask Marion and Lara, do you have any additional comments on risk factors or things that might carry added risk for COVID-19 in these population?
Yeah, Kevin, I think that's such a wonderful question and thought that, parents are asking all the time. And I think the data do show that there probably are going to be more hospitalizations in our patients who have had transplants. But one thing that's really important is that our children that are waiting for a transplant are also at very high risk. So just when we look at the studies that are going on, like the SPLIT database, the pediatric heart transplant database, the kids on the waiting list who still have all of these comorbidities, they too are very high risk. So I know we'll talk a little bit more about timing of vaccine, But it's not even just once you have the transplant, but also keeping you safe until you can get your transplant.
Yeah, absolutely.
I think you've covered really the main issues that we have, and certainly we want to ensure that people know there may be many reasons why someone who's had a transplant or who's waiting for transplant who has COVID gets admitted to the hospital, but certainly, and it may not all be related to COVID, but certainly that is a complication, and it's particularly for patients who are on the waiting list. That can delay the opportunity to get a transplant for a period of time, and that's something we definitely want to avoid. If at all possible, because we know there's still virus circulating in the community.
Absolutely. So now, an important question: should my child receive a COVID-19 vaccine? So we'll go through some of the more recent data that's been available to us. So currently in the United States, there are 3 vaccines that are authorized for use. So we have the Pfizer BioNTech mRNA vaccine, which is actually FDA approved for people 16 years of age and older, but also authorized for individuals 5 through 15 years of age. I'm very excited about that lower number now available to us. There's the Moderna vaccine, which is also an mRNA vaccine. It continues to be authorized by the FDA and only is available for individuals 18 and older. And then there's a Johnson & Johnson or Janssen vaccine that is slightly different. It is a viral vector vaccine, and it's authorized, again, for use in people in 18 years of age and older. So for today's discussion, we're really focusing mainly on the Pfizer BioNTech vaccine, which is now authorized in the younger age groups. So how well does this vaccine work? I know there's a lot of conflicting information that's out there, but based on a very large population study that was published in the New England Journal of Medicine, including against the Delta variant, the efficacy of 2 doses of this vaccine is approximately 88%, which means, and that's for symptomatic COVID infections. It carries an even a higher benefit for severe disease and hospitalization. When we ask questions about how well does this vaccine work in children, part of the answer is we don't yet know, because we haven't vaccinated enough 5 to 11-year-olds to really have vaccine efficacy data. However, what we do know from the early studies is that the vaccine is likely to be as effective in this age group as in older individuals. And so the way that these studies were conducted is they enrolled about 6,000 patients, and they gave them different doses of the vaccine, and they looked at how the immune response compares to older individuals that are receiving the adult dose, so 16 to 25 years of age. And what you can see in these middle blocks here are that the titers of the antibody responses were comparable between 5 to 11-year-olds who received a dose that's 1/3 the adult dose compared to 16 to 25-year-olds who received the adult dose. So based on this immunogenicity data, based on how the immune is responding to the pediatric dosage, it is felt to elicit the same immune response as seen in those young adults. And that's what's really important. Vaccine efficacy is a lot harder to get at because you need many more cases and a much larger study than is done in the clinical trial. However, in this trial, among the participants that were randomized to either vaccine or placebo, the vaccine effectiveness was greater than 90% for the pediatric dose. And this included just three cases of COVID-19 in the recipient group and 16 in the placebo group. And there were twice as many recipients of the actual drug than there were the placebo. So just demonstrating how effective this vaccine is. Now, again, this is a smaller subset of the study. This is not population-based data, but we do feel likely that these numbers are going to hold as we move forward as well in this age group. And these numbers informed the decisions from the FDA and the ACIP about approval or authorization of this dose, which was granted yesterday. And based on these data, based on the effectiveness, anticipated effectiveness of this vaccine, we expect that more than 55,000 cases of COVID are going to be prevented for every million children that are vaccinated. It's going to prevent close to 200 hospitalizations for young females, more than 200 hospitalizations for males. It's going to prevent more than close to 130 cases of MIS-C, which is an autoinflammatory condition that results from following COVID. And you can see the number of intensive care unit admissions prevented as well. So, the benefits of this vaccine, again, are not focused on preventing deaths in this age group. It's preventing severe disease, hospitalizations, transmission to others, and COVID cases overall. Marianne or Lara, do you have any comments specifically about the pediatric data that's been available so far for the early Pfizer study?
No, I think you've covered it really well. I mean, there's, as we know, the amount of data that we have is limited, and there's more data coming, and we're really looking forward to getting a more broad picture. But, there's also ongoing studies specifically looking at patients who are immunocompromised, and we're really looking forward to those so that we can answer some of your very specific questions a little bit more clearly.
Yeah, I agree completely with everything that my colleagues have just said. And, just to sort of emphasize the part that's just in the community at large, not even talking about our organ transplant patients yet, but, it's becoming a tale of like two different groups, those that are vaccinated and protected and those who are not vaccinated. And this is it's horrendous, right? Like, we should not have that happening. And so here we have a vaccine preventable disease, and we really look forward to more and more people being able to take advantage of that.
Absolutely. And as you mentioned, we'll talk more specifically about transplant recipients in the next few minutes. So just to mention, the Moderna vaccine, which is available in adults, also has a very strong response based on the preliminary data, or the preliminary press release, if you will say, from the company. So it looks very promising. Unfortunately, we've not seen the data, so I can't comment much further than that. But based on the press release, we're hoping that this is going to be an option for kids as well. They have not submitted for the authorization below 18. I think they may be waiting to do 6 to 18 altogether, but they will be a different dose in this age group, which is half the adult dose for the Moderna vaccine. And this is important because I think many of the side effects that we see, the mild side effects, the fever, discomfort, etc., those are related to the robust immune response that these vaccines elicit. And so making sure that the dose is correct is important. So more to come on this vaccine. In terms of the J&J vaccine, which I don't have any data, I'm not sure if there are data about pediatric patients receiving that vaccine, if there's even a pediatric study going on for that vaccine. So now for solid organ transplant information. Following the authorization of the vaccine in 12 to 18-year-olds, we have some data from small studies that have looked at immune responses in vaccine recipients in this age group. And it's not as consistent as in otherwise healthy children. So these are data from 3 small studies. The first included 45 pediatric solid organ transplants who received 2 doses of the Pfizer vaccine. Antibodies, and these are antibody-based studies, antibodies were detected and considered positive following dose 2 in about 3/4 of those patients. In a study of 38 adolescent kidney transplant recipients, just under 2/3 had a positive antibody response following 2 doses of the vaccine. And this was compared to 100% of the control patients that have those same antibodies measured. And then in a smaller kidney transplant, another study, 50% of patients had positive antibodies. And I think this is not unexpected based on the adult data that we've seen, particularly given that some patients receive their vaccines close to transplant and may not be expected to mount a full immune response because of the immune suppression. But antibodies don't tell the whole story of COVID vaccines in this population. They're still, the vaccines, even if antibodies are not detected, can still be effective because there are other components of the immune system that can respond. So when there was some data that came out of Israel during the Delta wave that looked at the success of the mRNA vaccine and found that it was effective against infection for 90% of individuals, but 71% of immunosuppressed patients. And so this included not just transplant recipients, but recipients of other of immunosuppressants for other indications. And importantly, it was effective against symptomatic infection in close to 95% of all individuals, but 75% of immune-suppressed patients. So even though those antibody responses, which may be somewhere between 50 to 75% in most of the adult studies, the actual protection is higher than that. And we expect the same to be true in younger patients as well, although we don't have any data on 5 to 11-year-old solid organ transplant recipients yet. But I think the effectiveness is going to be higher than some of these antibody studies report. All right, and so now there's a lot of questions about third vaccine doses. So currently the mRNA vaccines are authorized as a 2-dose series. The Pfizer vaccine is 2 doses, 21 days apart. And it's likely in this 5 to 11-year-old age group that is going to be the recommendation as well, as it currently lies in terms of additional doses. So the FDA in the end of the summer authorized an additional dose, what we call a 3rd dose, for individuals who are immunosuppressed and not expected to respond as robustly to the 2-dose series. This is different than a booster dose that might be given in other individuals, which is given after a period of time. And I'll show a slide later that'll explain the difference, because I think it is important to recognize. So the 3rd dose for immunocompromised individuals is supposed to be given no sooner than 28 days after completion of the 2nd dose. And the difference is sort of what we're trying to do with the dose. So boosters are given to people whose vaccine response may decrease over time. These are the general population after 6 months of time is the current recommendation. And you can see on the figure on the bottom, you give 2 doses, you get a good response, but that might start to fade a little bit. And so we give a booster to get back up to where and maintain that response. An additional dose, a 3rd dose, is given to people who may not have fully responded to a 2-dose series. So on the right-hand side, this is what we're currently doing or recommending for solid organ transplant recipients. And the idea of the 3rd dose is that it's to get the immune response up to the equivalent of 2 doses in other individuals. Lara, Marion, I don't know if you want to comment on what we expect will be the recommendation for 3rd doses for our 5 to 11-year-old transplant patients.
So I'm happy to, I was just typing a response in the box, but yeah, so currently individuals who are 12 and over are eligible for that 3rd dose, not the booster dose, but the 3rd dose in a 3-dose series based on the CDC recommendations from August 2021. The current recommendations, it does not appear that there's going to be an initial recommendation for a 3rd dose in children 5 to 11, but certainly that will be under review. And in the clinical trial that's ongoing in post-transplant patients, a 3rd dose is built into that trial in order to gain information related to that.
Yeah, and I think that's probably the reason that the advisory committee on immunizations, that gives advice to the CDC to make those recommendations on all the vaccines that we have for our country. I think that's their reason that they did not recommend it yet, because they know this research study is ongoing and we're going to have data to base it on. So I think in order to be really careful and ensure the safety of everything, which is appropriate, I think that's why they're waiting.
And there's also a question in the chat about a potential booster or fourth dose. And certainly that won't be decided in children until well after the question of a third dose is discussed. I think it's also important to understand that, it may be that those who are 12 to 17 may not fall into the same category of needing a booster dose at the same interval as those who are older. We certainly have seen that the older individuals appear to have, even after transplant in that population, there is a difference in how old you are and how well you respond.
Right. I think that's a really good point, because people sometimes say, well, I have my child's 7 years of age, but they are the size of a 12-year-old. Shouldn't they be getting the bigger dose? But in fact, it's really on the immune response of a younger person. So these younger children have a more robust response. And I think, as Kevin showed on one of the earlier slides, they really do have as robust a response with the half dose or the 1/3 dose, depending on which vaccine we're talking about. So they don't need as big a volume or concentration of the mRNA. So
certainly there's questions also about, which immunosuppressive my child is on, and how does that impact their capacity to respond. That's something that we're still learning. Certainly we know that people who are closer to the time of transplant don't respond as well to vaccine. They're also at higher risk for having severe COVID. So those things go hand in hand. So, the timing of when you should talk with your transplant center about when they would like you to get vaccinated. And we certainly recommend that no one make any changes independent of their transplant center to their immunosuppression while they're getting the vaccination. And the question about antibodies alone, we don't recommend checking antibodies related to vaccines, because we do know that there are patients, and not an insubstantial number of transplant recipients who don't necessarily mount antibodies, but they do develop a cellular immunity, which is actually what helps control the virus significantly. So it's all a balance and a little bit of a dance. And unfortunately, we don't have exact answers. But it's important to talk with your teams, and don't make any changes independent of your teams. Make sure you're talking with them, because the last thing that anybody wants to have happen is that you make a change and there's a complication related to adjusting in immunosuppressive medication without the knowledge of your transplant team in order to try to get a better response to the vaccine.
Yeah, and I think to that point as well, when people are asking about fourth doses, fifth doses, et cetera, much of what governs a lot of these decisions about boosters and additional doses is what's going on with the pandemic and the cases in the community. As more people get vaccinated, we hope that we're going to have sustained periods without these spikes. It's likely there's going to be community transmission for a prolonged period of time, but the likelihood that your child's going to be encountering the virus also dictates how robust and how often we need to give these boosters. So I think that time will tell. So I wouldn't plan on fourth and fifth doses yet, but it's continuing to be discussed as we learn more and we get more people vaccinated. So as Lara mentioned on the bottom point here, we do not recommend measuring antibodies to help decide if your child should receive a third dose or a booster dose. And one of the reasons is that there are different types of antibody tests that are available. Some measure antibodies to a spike protein, which is the component of the virus to which the vaccine creates antibodies, as well as natural infection. So measuring antibodies to that is different than measuring antibodies to what's called a nucleocapsid, which is a different component of the SARS virus that is not contained in the vaccines and tells us more about natural infection. And not all tests are available at each location, and I think their interpretation is vastly different. The other important part is that these antibody tests are different from one lab to another. And so you can't look at a number that you receive from one lab and translate that to another lab and understand how to use that. And as Lara mentioned before as well, antibodies are not the whole story. So it's very important to understand your cellular immune response, where you are in relation to vaccine. And we just don't know enough about these numbers and the antibody information to say, this number you need to give another dose and this one you don't. So instead it's following the schedule and continuing to be vigilant about those precautions. We do want to emphasize that COVID vaccination is strongly recommended for not only all eligible patients 12 years of age of older. I apologize for putting this slide together last week, but now 5 years of age and older as well. But also household members and other close contacts. It's going to continue to be important to protect solid organ transplant recipients by being healthy around them. And so that means anyone that's in close contact that takes care of your child who's a transplant recipient really should be vaccinated, even if your child is vaccinated, him or herself. And then we want to mention discussing the timing of vaccination, because this is an important point. So ideally, we would like to vaccinate someone at least 2 weeks prior to transplant. We don't always know when transplants are going to occur, but if your child's on the wait list, the idea would be to vaccinate, and if you have an elective transplantation, to wait 2 weeks to allow an immune response to develop. If the vaccine cannot be given prior to transplant, or your child's already been transplanted, we recommend not starting the vaccine series until at least 1 month after transplant to allow for an adequate immune response. And as we mentioned, the farther out from transplant, the lower immune suppression your child is on, the more likely he or she is to have a robust immune response. Lara and Marion, I don't know if you can comment a little bit on, what do you recommend to families who are waiting on the transplant, on the wait list, but don't know when their transplant is coming?
I recommend get the vaccine as soon as possible, not only for them, but also for their entire family, because of course we know our children do not live in a vacuum, and we don't really want to keep them in a bubble longer than we have to. And we'll talk about, I know we're talking about safe living in a little bit anyways, but in terms of when we're evaluating families and children to go on the transplant list. So before we even get full approval, before they've even decided, I'm like, let's not wait. Let's get you vaccinated. Let's get everyone vaccinated around you, because the more time we have for you to develop that protective antibody response, for those children to develop a protective antibody response, the better they're off they're going to be going into the transplant. Lara?
No, I agree.
Have either of you had an instance where a child's been vaccinated before transplant and a question has come up about whether they should be vaccinated again?
So that is a question. It depends oftentimes around the timing of when they were vaccinated pre-transplant compared to when they had their transplant, what their underlying disease was, and what other medications they were taking at the time of transplant, and what their risk is. And all of those things go into the factor to determine whether or not they need to get an additional dose or two after they're transplanted. And that's something you should talk about with your transplant center.
Yeah, and I think Lara's point right here is, I know the three of us are the ones talking, but your transplant center has really smart people and smart ID people that are working with them as well. And so those are going to be your first, that is really your first important group of people, is to talk with them about their recommendations. But, luckily these mRNA vaccines are not live vaccines. So if you get it and an organ becomes available tonight or tomorrow or the next day, it's true, it's not going to have time to give you any bang for your buck, but it's also not going to have caused any harm to take your organ right then too. So, so I think there's no reason for us to be waiting, unless, of course, they're on other medication that might impact, like maybe we're going to get their nutrition better, your doctor will want them to wait in those situations. So always talk to your doctors first.
Absolutely, great points. All right, so I think the last section that we have, or one of the last sections, is about the safety of COVID vaccines. And this is obviously a key and important piece. So when we look at transplant recipients compared to the general population, the safety profiles of the COVID vaccines are similar. The vast majority of adverse events, or what we say adverse events, but really side effects, are mild. These are things like headache, fatigue, fever, injection site pain. And these are common in the 1 to 3 days after vaccination. And that's true in transplant recipients as well as the general population. And currently, there's no information to suggest that transplant recipients would be at higher risk for side effects from the vaccines than anyone else. One particular side effect that is important to comment on because it pertains to younger patients, particularly adolescents, is about myocarditis. So the question comes up when talking about COVID vaccines in the 5 to 11-year-old age group is, what is the risk for myocarditis? And the answer is, we don't know. This is a side effect that occurs so rarely, there's no way to know based on this trial that was done or the trials that are being done to understand vaccine immunogenicity and efficacy. This is a side effect that occurs in less than 1 in 25,000 individuals. And so in order to understand that risk in the 5 to 11-year-old age group, you would have to have a trial that's hundreds of thousands of children, and that's not something that can be done. And so the FDA conducted their benefit and risk assessment based on several different sort of situations to understand whether this risk of myocarditis would outweigh the benefit of vaccination. And so I just want to highlight a couple of pieces here because I think it's just important to understand how they weighed this risk benefit. So they assumed that that vaccines in this age group are going to be 70% effective against COVID cases and 80% effective against hospitalizations. As I mentioned earlier, those numbers are probably very conservative estimates. We think that based on the early data that those numbers are actually probably higher than that. But that was on purpose. They wanted to underestimate the benefits of the vaccine. The risks that they looked at included excess cases of myocarditis, and related hospitalizations attributable to myocarditis. And they assumed that the rate of myocarditis in 5 to 11-year-olds is going to be the same as that in 12 to 18-year-olds. And we don't know that that will be true. It may overestimate the risks of myocarditis, since adolescents tend to be individuals who experience myocarditis from other causes more commonly than younger children. So those are important caveats to recognize when we look at these risk-benefit information. So what they found when they looked at different scenarios based on the incidence of COVID-19 in the community, looking at vaccine efficacy, if you actually increase those numbers from 70% to 80% or 90%, and if you looked at those instances, the model result indicated that the benefits of a vaccine are highly not only dependent on how those numbers are weighed, but the model predicted that the benefits of the COVID vaccine in this age group outweigh the risks for all of the scenarios, except for one scenario that they tried to model, which doesn't seem particularly likely. And so if COVID-19 cases were to be extremely low, such as the rate in June, and the risks of the COVID vaccine were to be extremely high, then the risk-benefit ratio is less clear, and that there might be more hospitalizations from vaccination to COVID-19. And the reason that I mention this, I know it sounds confusing, is that they wanted to look at how do we adjust all these numbers to make it so that the risk outweighs the benefit. And the fact is this incidence is just not what we've seen, and we're not what we would expect to see moving forward in terms of how likely it is a child is to be infected with COVID-19. And so under all of the more realistic scenarios in which we look at the benefits of the vaccine compared to the risks, the benefits far outweigh the risks. And so the vaccine was authorized. So Lara and Marion, I don't know if you want to comment on this piece at all. I probably made it more confusing, but I wanted to make sure that we comment on this because I think that this is what has garnered some attention from some of the anti-vaccination side in regards to vaccine in this age group.
Yeah, so I think you covered it incredibly well, and it is confusing. So if it got more confusing, I think it's just because it is a confusing thing. We don't understand 100% why some of these people very, very rarely are getting myocarditis. It tends to be in these young adult males more than the females, and and also it seems to be mirroring what we see in terms of the age and the gender or the sex that we see for myocarditis that's not related to the vaccine. So, so I think that in the younger children, we're probably going to see less than we see even in that very small population of young adult males. Having said that, myocarditis from the vaccine has been well controlled and easily controlled. And COVID can cause myocarditis and can cause cardiac failure. And so I would be more worried about the virus, the infection, than the vaccine. So I think that you said it very well. I don't have a lot to add. I don't know, Lara, did I just confuse things more? We'll let you straighten it all out for everyone.
I'm going to apologize if there's a dog yapping in the background. Someone's delivering something to my door and my dog is not being very cooperative. What I would say is, I think it's important to remember that, myocarditis is a rare event. It rarely occurs, but it does tend to occur in a population of adolescent boys and men during this very particular window. And there was an increased signal of that, but there's also an increased signal of myocarditis related to natural COVID infection, which is well above the background that we would normally see. So I think that, is how the balance of the risk of myocarditis related to the vaccine still is less than the risk of still is less than the general risk, and actually clearly makes the vaccination of higher benefit over the risk of myocarditis. That population, between 15 and actually it's between about 16 and 30 is where most of those patients have had myocarditis after vaccination. It doesn't appear that as we've moved down the chain to younger and younger children that we have the same effect, and that may be related to the natural course of the development of myocarditis, specifically post-viral myocarditis that we see naturally out in the community. So we do anticipate that we will see fewer events in those who are 5 to 11 because they're not predominantly at risk for this based on natural history.
Yeah, I even have one other comment, and we don't know the exact cause of it, but it might be an immune response. And if it is an immune response, I think for our organ transplant recipients, we'll anticipate it being even less common still. But again, that's just pure hypothesis at this point.
Yeah. And I think another question that often comes up is, are there children that are at higher risk for myocarditis? And particularly in the transplant population, this is such a rare side effect. I know we keep saying that, but it truly is. Even in the group that age range that Lara mentioned is the highest, it occurs most frequently. It's 1 in 25,000 per, fully vaccinated individuals in that age group. So we don't have specific, there are no known specific risk factors for this. And so I think that it's just an extraordinarily rare side effect, and that everyone will be paying very, very close attention as this vaccine rolls out in the coming weeks. But we think the safety vastly outweighs that very minimal risk.
And I would just add, just because some of the questions, the episodes of myocarditis, almost all, the majority of them that have a full report, people have completely recovered from these. Many of them have been mild and self-limited, not even requiring any intervention. Some people have had interventions, including steroids and other anti-inflammatory medications, but the recovery rate is very good. The symptoms are what you would think of, and many of our cardiac transplant families on this call might know them already, would be, fatigue, chest pain, shortness of breath, difficulty breathing. And if you do have symptoms within the first, few days after the vaccine, you should contact your transplant center and let them know so that you can be evaluated.
So lastly, we want to make sure that we discuss this question as well, whether you should take any special precautions for my child. So getting vaccinated is not a free pass to take your mask off, and it's not a free pass to go and resume life as it once was, unfortunately. And so we need to continue to be vigilant. There are still cases out there. We do see breakthrough cases on occasion. And so the recommendations for preventing COVID-19 continue to be in place, particularly for higher risk individuals like transplant recipients. So even if your child is vaccinated, we would suggest that he or she wear a mask, particularly in close quarters, indoors, around other large groups, and continue to try to maintain distance when possible. Outside is a safe location, and cleaning your hands frequently. These sort of marching orders that we've given since the start of the pandemic remain true even with vaccines available. And so as take-home messages, I want to make sure that we just leave a few minutes in case there's questions in the chat that we haven't addressed yet. I want to emphasize that these vaccines are safe. We are very excited about them being authorized in younger age groups, and are recommending them strongly for pediatric solid organ transplant recipients. In terms of their effectiveness in pediatric solid organ transplant recipients, we don't have data. We don't know. We think that they will be effective in the vast majority, but it's important to continue to take those precautions to prevent exposures. And so with that, let me just stop sharing my slides, and I will open it up to the question.
I wanted to add on to that because a lot of the questions that are coming up are having to do with, are we going to have to wear masks all the time? And, I really feel like what Kevin has said is so critically important. We are still in the pandemic, and our families and we are still at risk. And so even if you're not immunocompromised, if you're in a place where there's a crowd of people, we need to protect ourselves, to protect our children and to protect our families and to protect our elderly loved ones as well as ourselves. And so we're still in it, and we still need to be able to help wear it. And, I was talking to some of my families, my transplant recipient families, and one mom said to me, which I thought was such an insightful thing, was, because the schools are all masking now, it actually makes my kid feel better, because during flu season, I always made him mask after his heart transplant. And now he doesn't feel like an outsider. So it sort of normalizes it. So I know we want to be able to normalize their life, but I think there are ways to just say, you know what, it's okay to wear a mask. It's okay to wash your hands. My goodness, guys, we had one influenza death this entire last flu season because we didn't have influenza and we didn't have RSV, because everybody was washing their hands like crazy and masking like crazy. This was like, we can prevent some of these diseases by being really careful with how we approach every infection. So yes, we are going to do better than we are now. And as the rates go down, and when you're outside or when with your family, who everyone's already been vaccinated, there'll be lots of times to take your masks off, but we're not there yet. We're just not there yet.
Have we addressed the question? I know that there's one more question, and it's asking how soon after your child receives an organ transplant are they going to be eligible to get the vaccine?
Ricky, that's a great question. So some of it is a little bit dependent, right? So it depends on, depends on what medicines they got at the time of their transplant, what medicines they're currently on, if they've had any complications. So that's a great question for their individual provider. The American Society of Transplantation doesn't recommend giving it before a month post-transplant, but oftentimes that may be even a little bit too soon for some patients, especially if they've gotten medications like thymoglobulin, or if they've gotten other medications that would impact the capacity to respond. If they've gotten rituximab or something like that, that's going to suppress a certain specific part of their immune system that makes the vaccine work less well.
But in general, a minimum of a month before you're going to have any immune response, don't you think?
Yeah.
There was another question that was submitted prior to the event, and it was regarding monoclonal antibodies. And I think that it would be important to talk about monoclonal antibodies before vaccination and after vaccination if a patient does get COVID-19.
Yeah.
You want me to answer that one?
Sure.
Go for it.
Lots of us, I answered it in the chat already, but I'm happy to answer it live as well. So monoclonal antibodies are approved for children and adults who are over 12 years of age and older and weigh more than 40 kilograms. There's two reasons based on the emergency use authorizations that they can be given. One is if someone has COVID and is mildly symptomatic, but not yet hospitalized and not having an increasing oxygen requirement or anything like that. So they can be given for treatment. And the other circumstances, they can be given for post-exposure prophylaxis in patients who are vaccinated, partially vaccinated, or unvaccinated, if they would not have been anticipated to have been responded robustly to the vaccine. So that includes pretty much all solid organ transplant recipients that have gotten a post-transplant vaccine. And they're available if you have someone in your home or you have a significant exposure that's very well delineated. Now, each individual center will have its process for how these monoclonal antibodies are eligible and who is eligible for them within their jurisdiction. So it's important to reach out if you have a significant exposure and you're 12 or older and weigh more than 40 kilos, which is a little bit tricky sometimes. I've had people ask me if they can wear, put rocks in their pockets. Generally not, but if I didn't, generally not. Or if they've had a significant exposure, they should let their transplant teams know right away because they may have access to monoclonal antibodies, even if they've been previously vaccinated.
And there's another part to that too. Once you've gotten the monoclonal antibodies and then you're eligible for the vaccine, because of the monoclonal antibody, we actually want you to wait at least 90 days before you get vaccinated so that you have an immune response. And I know one of the other questions that came up in the chat from Dr. Kelly was regarding, well, what if you got IVIG? So not the monoclonal antibodies, but just immunoglobulin that we give for many of our patients have had to receive some type of immunoglobulin treatment. So in the beginning of the pandemic, nobody had any proteins against COVID-19 because this virus did not exist in our community. So anyone who donated blood to make those products, there wasn't any in it. So really people were like, yeah, it's not going to matter. But as we go further and further along in the pandemic, I think the donors will more likely have some proteins, some antibody against COVID. So that may change, and it may depend on how much immunoglobulin you got. So For the children that have had this multi-system inflammatory syndrome of children that we call MISC that Kevin talked about, they get a very high amount of IVIG. And if those children need to be vaccinated later, we are waiting. The recommendations haven't been official yet, but I know that they're coming out soon and they'll be for 90 days as well.
Yeah, there's a
Okay.
question about whether monoclonal antibodies would be available for kids under 12. I don't know where the studies lie on that. I know that there was going to be one, but it got paused. So I'm not sure if they picked that back up.
So they're not routinely available. However, in very, very special circumstances, individual providers can apply for an emergency use, an exemption that allows them to use it for younger children. And that has happened in some circumstances, but that is not something that generally will happen within 24 hours of you being identified as having an infection. So it's not routinely available, and it's really uncertain. There's newer products that are going to be are coming on the market, and they may have longer duration of action, but we're not certain how they're going to be, who's going to be eligible for those yet.
That's all the time we have for questions today. Guest speakers, is there anything else that you wanted to touch on before we close out the session?
I just want to thank everyone for coming and letting us, talk with you about this. We know it's a big decision. We know a lot of people have been waiting for this. And we also know that you are in great hands with your individual providers, and they have tremendous amounts of knowledge, and we encourage you to speak with them, especially if you have concerns about the vaccine and about vaccinating your child, so that you can, make the best decision for you and your family.
Thank you. So for those of you who are interested, patients 5 years and older will be eligible to join the COVID-19 vaccine trial through Johns Hopkins University once the Pfizer biotech vaccine has become available and approved for emergency use authorization for the 5 to 11-year-old age group, which I believe happened today. Only patients who choose to get the vaccine will be enrolled. Details about the trial can be found at www.vaccineresponse.org. Thank you to Transplant Families and for discussing COVID-19 vaccines for recipient children. Slides and videos will be available within a couple weeks of the presentation on our website and our YouTube channel. An email will be sent out when they are available. Before we sign off, I'd like to remind you to join us tomorrow for the CareDx Transplant Families partnered event on how to advocate for best care as a patient caregiver. You can visit the Transplant Families Facebook page to register for that event. Feel free to reach out to our Executive Director, Melissa McQueen, via email at melissa@transplantfamilies.org if you want to know more about our organization or have any questions. You can also join us at transplantfamilies.org to contribute or watch past webinars. We'll see you next time. Have a great evening, and thank you for joining us.